Tracline hosted and organised its final mobile point-of-care roadshow at the British Medical Association, where an audience of NHS delegates, clinicians, IT managers and project managers heard from the experience of their peers implementing mobile computing solutions. Among the benefits shared by speakers from a range of healthcare settings included improved patient safety, greater staff productivity and the compelling business case that should be made across the NHS.
We use mobile point-of-care technology in a number of ways. The first time we implemented it was for our electronic prescribing and medicines administration project. So doctors prescribing for our inpatients, pharmacists verifying those orders that they were safe and appropriate for the patient, our pharmacy technicians ordering the supplies of the medicine, and our nurses recording administration of those doses at the bedside.
We use mobile point of care by ensuring that our clinical staff have access to the patient record when they're in the patient's home. So we're looking at a range of solutions around mobile technology, laptops for some, tough books for others, and trying to ensure that each member of staff has access to the electronic record in a domiciliary environment when they're actually seeing people at home.
A number of benefits have been achieved from mobile point-of-care technology. The first of all would have been safety. We've done some analysis on a number of patients who were using paper records, and then after the implementation of electronic records and mobile point-of-care technology, we managed to reduce the severity of errors within those patients by 11%.
There's a number of benefits. Firstly, in terms of patient safety. So when a clinician sees a patient, the first thing that they can do is look into an electronic record that in South East Essex, 80% of our GPs are also contributing to that record as well. We can also ensure that staff are spending less time travelling backwards and forwards from their clinic looking for information. They can go straight to the first place they need to see the patient. The work's organised on there. They can see the patient there far more effectively and efficiently, and then move on to the next patient, so they reduce their administrative burdens.
In addition to safety, we've seen clinical effectiveness improve. So we've looked at prescribing of medications in line with guidance, mainly in our surgical areas. The last way that we've seen improvements in quality of care is in the patient experience. So now we can get our discharge summaries out to patients electronically, so when they get to their GP, there's no missing information, and they can see exactly the medicines that they were administered while they're in hospital.
We need the information at the point we see the patient. Now, whether you're talking secondary care, in a hospital environment, or whether you're talking community and primary care, the issue is exactly the same. When I'm with a patient, I want the information at my fingertips. When I see a patient and I gather information from, say, a history taking, I need to input that information once. That's my clinical requirement, and I need to do it when I'm with the patient.
Medicine needs to be recorded at the patient bedside, but the whole medication workflow isn't at the patient bedside. Obviously, we have to get supplies of the medicine, which might be in a drug cupboard. For our higher risk medications, you might need a double signature from another nurse or a double electronic signature, so making sure that you're not disrupting that other nurse and those sorts of workflows that lead to the efficiencies of mobile care technology.
Well, it's been very, very interesting to get the feedback from both primary and the secondary care that there is some genuinely good work going on around the whole country where it's irrefutable that this is actually working, and working on a grander scale than perhaps anybody realises. So what may perhaps have seemed a good idea at the beginning of the conference season, we can now say for an actual fact it's been absolutely super.
I thought it was particularly useful to find out what other trusts around the country were doing. I was particularly interested that other people had come across similar sorts of things that we'd thought about, and that they hadn't found them to be problems. For instance, security of MCAs, which all the trusts said they hadn't found to be a problem, which everybody's very concerned about. So yes, a variety of things really, but that other people have been working on this, and working on it in an extremely detailed way, which I just was not aware of.
I think the reaction from the attendees has been nothing short of super. They all absolutely believe in this thing, and it's not theory, it's actually working now, and that I would strongly recommend their colleagues across the country to look into it, find out how you do it, because it's all there now.